Hi guys, it's John Adamson, the Rehab and Documentation Guru. Well, I did something I said I wasn't going to do last night. In a moment of weakness, I got on social media. And that's never a good idea right before you go to bed. Fortunately, I didn't get too roped into the commentary, but I did note a number of comments concerning goals, and more specifically, the number of goals. And I'm revisiting this topic that I just covered not too long ago in a video on number of goals for home health. So I'm going to talk about number of goals, period. And I'm going to talk about some ethical concerns. I'm going to talk about proper care planning. I'm going to talk a little bit about Medicare. So let's talk first about Medicare. So what is Medicare's expectation about goals? But I want to go to a more broad term and talk about care planning. Now, obviously, care planning contains goals. So goals are a part of your care planning. You evaluate a patient, you find out they have issues. From your findings, therefore, you care plan. You develop goals based on that, and then you develop an action plan to achieve those goals. So care planning has to do with goal formation. And Medicare has a perspective on this. So I want to talk for a moment about post-acute care, because post-acute care settings are the most heavily regulated in terms of care planning. And when I talk about post-acute care, I'm talking about LTACs, SNFs, acute rehabs, and home health agencies. Now, in those particular agencies, in an LTAC, you have a comprehensive assessment called the CARE tool. I did say LTAC, I believe. In acute rehab, you have the IRF-PI. In a SNF, you have the MDS, and in home health, you have the OASIS. Now, it is an expectation, according to Medicare guidelines, that not only are these tracking tools, but they are care planning tools. In other words, if you find out an issue is revealed by one of these assessments, then you are required to do a deeper dive, a deeper assessment. A problem identified, therefore, must be care planned. It might be that you need therapy to care plan related to this particular issue. It might not be. And of course, that's the beauty of post-acute care settings, is that therapy is just one of many skilled services that can be provided. So when you identify a problem, the first question is, in these settings, who should be developing the care plan? Now, obviously, oftentimes it's interdisciplinary or multidisciplinary, however you want to use the term. I'm not a big stickler on that. And so sometimes you all get involved. Like in home health, for example, the issue of pain must always be care planned regardless of if the patient has pain or not. Or preventing acquired pressure ulcers. This also must be care planned and must be addressed by all disciplines. So therefore, it must be a goal. But if you do find a problem and you don't do something about it, you can face some fairly serious ramifications if you don't address problems identified in post-acute care, because those identified problems often cause injury to the patient. And God forbid your agency creates problems for the patient by identifying problems and not doing something about it. Now, I'm going to weave that into the whole goal discussion by a therapist. A lot of therapists are indicating that they have a basic formulation of the number of goals for their patient. And that defies patient specificity of care planning. Every patient is individual. There's no set formula. 3 to 4, 2 to 3, whatever people are indicating, that is not accurate. Patients deserve individualized care, which means you will individually write goals for them. So you might have one patient who has 2 goals. You might have one patient that has 8 goals. You might have one patient that has 5 goals. It does not matter. It's the patient specificity that's important. Now let's talk about that for a moment in terms of care planning as well. One of the things you care plan is the interventions you need to do to get to the goals and your expected frequency and duration of treatment. And in some cases, intensity, meaning number of units or minutes of care that you will be delivering. So think about this. It's pretty straightforward math. The more goals you have, the more care a patient needs. By developing a care plan that has a minimal number of goals, like let's say 2 or 3, you're basically indicating to the third-party payer that the patient does not have a great deal of skilled need. If you've got 8 goals, you're basically indicating the patient, compared to the patient with 3 goals, has a lot of care needs and is going to need more frequency, intensity, and duration of care. So it's pretty simple math. So if you cookie cutter approach patients, and let's say you're in the habit of writing goals that are, let's say 4 goals for every single patient, and yet you've got patients, one patient requires 2 weeks of intervention, one patient requires 8 weeks of intervention, that just does not look very patient specific. And that patient that's always getting the 4 goals, you're not really answering why one patient needs more care than the other through the process of care planning. So that's part of the problem. So goals, it's got to be patient specific. And then I already mentioned that it's got to be based on identified problems that the patient has. Also, goals are a means to measurement. And if you are treating something, you must have a way to track that measurement to determine the clinical efficacy of what you're doing. So if you don't have a goal for it, you cannot treat it. I've mentioned before that if you don't have a measurement for it, you cannot treat it. That is accurate. If you don't have a goal for it, you cannot treat it. So both of these statements are true and accurate. So we need to make sure that if you are addressing something, you have a means to track your efficacy. Now, some therapists have said, well, you just write functional goals. Well, let me tell you part of the problem with that. Obviously, functions are the key area we're working on towards. However, we have to have a way to address what the underlying impairments causing the functional deficits are, and that's where our skill comes in, our root cause analysis, our assessment and analysis of the root cause, the underlying impairments that are creating the functional deficits. So once you identify that root cause, you have to have a way of tracking whether or not you are clinically effective in treating that problem. And the number one way you do that is with goals. So let's say you have goals, and let's just use a PT example for bed mobility, transfers, and level ambulation. Now, that's fine. You could do that, but there's a whole lot of things that can cause problems in those functional categories. So you're treating primarily the underlying impairments to get to the goal. However, goals are used to prompt therapists to measure things, and if you do not put them in a goal, you forget to measure them. And why do I say that? Because I've looked at thousands of claims in 10 years, and I can tell you honestly, if therapists don't put things in goals, they forget to measure them. So put them in your goals. That'll definitely make sure you stay on target for measuring them. And I was going to say something else about this, but I thought I was being fairly organized in my thoughts, and I have forgotten. I may revisit this topic because I think it's an important one, and there's still a lot of bad advice that's being propagated, sometimes by well-meaning people. I do understand that the more goals you have documented is an implication on your amount of documentation time. It implies more documentation time with more goals. So obviously this is a problem for a therapist. I understand this. However, I want to err on the side of identifying problems and doing something about them rather than neglecting them. The other thing is you may not get to certain goals in your particular setting. So you do have to identify the appropriateness of the setting for the goals. So this is an important topic. If you are in a post-acute care setting that involves a patient still living in a facility, LTACs, acute rehabs, and SNF, there are some instances where they might have a problem in that area, but you don't address it in that setting. So for example, the intervention community reintegration, 97537, used by OT a lot. One of Medicare's general expectations is that in a setting, an inpatient setting, that will not be an appropriate intervention generally because they're not in the community yet, therefore you don't have to be addressing it. When they get to the home health setting or outpatient, then addressing community reintegration is perfectly appropriate because it's consistent with the setting the patient's being treated in. So that's something to keep in mind too. So you may identify a problem and there's a delayed gratification to working on it, and that's going to have to be delayed to the next setting of practice. So some things to keep in mind when you're prescribing goals, but if you're seeing people that are documenting or are stating that they have a certain number of goals and that's what they go by, don't listen to them. They don't know what they're talking about. Goals are always patient-centric. They're always based on identified problems. If you identify a problem, you don't do something about it. You've neglected the patient's needs. But sometimes you will delay things based on the practice setting that you're in. This is John Adamson, the Rehab and Documentation Guru, going to see my first home health patient, and I'm going to be developing a care plan because I'm doing an admit. Take care. God bless.